actually freehand. So you may not, you may see my arrow, let's stick to that. And when you can't see my arrow, let me know. Now, again, I can't move this.
Just click in the center. Yeah.
Okay.
Slides are moving now.
Okay, excellent. And you can't see my arrow again now, right?
No, ma'am.
Okay, so now I need to find a way to
We
laser
can-
pointer. Okay, I've got the laser pointer.
Yes, ma'am.
It doesn't seem to want to stick to this. It's swapping to the pen and then shutting me down. So we'll try to just manage. And I don't want to spend a lot of time on grading because this is really not very important anymore, except for this. So for a long time, we were grading 1, 2, 3A and 3B. And over classifications, this has changed. This grading depends on center sites and central class content. But now grade 1 through 3A are all called classic follicular lymphoma. This is a very welcome change in our classification because there was really no clinical or prognostic reason to count or separate these features. But if you have grade 3B, which means that you have follicular proliferation, but all the cells in there are sheets of large cells, you call it follicular large cell lymphoma, and that is your nodular or follicular counterpart of a diffuse large B-cell lymphoma. So this is the only grading that is required now, and it is, as I said, a very, very welcome change to all of the grading we used to do. Okay, so there is a lot of fancy immunohistochemistry that you can do, and this is not even all of them, but I have just summarized what you would typically want to consider doing. You don't need all of this. You guys were already able to make the diagnosis on very few things. Right. And I want to, so, this particular one actually has dim BCL2, as you can see here. Very careful when you evaluate BCL2 in that you should always look at a CD3 to know whether the BCL2 signal is coming from T cells or is it coming from B cells. So when you don't have a bright BCL2, very important to compare with CD3 because T cells are normally BCL2 positive. And so we talked about a translocation. The protein BCL2 can be expressed without the translocation. So it's positive in normal T cells and it's positive in a lot of other things that are not actually helpful or may even get in the way of the diagnosis. When you have I'll ask this as a question. What are the lymphomas, or maybe I should say, what lymphomas don't have BCL2? There's only 2 to remember, because most lymphomas have BCL2. They may not have the translocation, but the protein expression is there. When you have architecture like this, having BCL2 is meaningful, and it's helpful to make a diagnosis. But when you don't have architecture, there are 2 lymphomas that you should remember.
Lymphoma.
Excellent.
Mantle cell.
Mantle cell can have BCL2. Think of T cell lymphomas, because many T cell lymphomas have BCL2. Protein expression, not the translocation. I'm only talking about the protein expression now. So it's actually ALK-positive anaplastic large cell lymphoma. It usually lacks BCL2. So one each, just remember that, so that when you see a BCL2, don't let it mislead you, because it's not BCL2, it does not equal follicular lymphoma, right? And in an era where you are going to more and more frequently see core needle biopsies, partially diffuse and partially follicular proliferations, it can really be misleading, because if you have a differential diagnosis between a follicular lymphoma and marginal zone lymphoma, both of them can be BCL2 positive. Cell size may be difficult, and they both may have a nodular appearance, because you are left wondering, is this a follicular lymphoma that is expanded out, or is it a marginal zone lymphoma that is doing follicular colonization and disrupting a follicle, inside out versus outside in? And that pattern can be very difficult to sort out because it's all CD20 positive and BCL2 positive. So the interpretation of your stains is also very important. So I'm going to actually focus on these 2. I've given you a larger, and I've asked you, so this was the CD20 on the particular case I showed you. And this is a little tip. I've asked you for a differential diagnosis. Does anyone want to give me a differential diagnosis for this CD20? This is all you have. You have one stain and you have to make a diagnosis. You already pretty much made the diagnosis here, but what is the differential diagnosis for this? So what am I trying to show here with the CD20?
Cells.
But what about the B cells? If this were a tonsil or a normal reactive lymph node, with the CD20 look like this? So what does it look like? Lots of follicles. But what about all this?
It is present throughout the follicle.
Right. And it's just intensely, everything is positive. It's so overwhelmingly positive, right? And you would not see that if you were looking at a reactive lymph node or a tonsil. So this is the pattern I'm trying to point out, that it's very full. It's full of B cells. This idea that there are so many B cells here, that's just overwhelming the normal architecture. But the architecture is still relatively intact. I mean, the normal architecture is gone, but the follicular architecture is still maintained. So you have a really high number of interfollicular B cells, right? And then that comes out in some of the other stains. 10 is getting it. Sometimes 10 and BCL6 are not always very good at getting the interfollicular component. So 10 may only highlight these. BCL2 is usually very good at getting the interfollicular component, but as I said, it's not specific to a particular lymphoma. So that can cause problems like marginal zone, mantle cell. They're all going to have this pattern. Okay, so this fullness, I still am waiting for the differential diagnosis of when you have a follicular proliferation or a nodular looking proliferation, and you have a BCL2 like this with a very strong interfollicular. What would be your differential diagnosis? So can you have a CD20? I don't want to make it difficult. Can you have a CD20 that looks like this in a reactive condition? Simple answer. Can you think of any reactive condition that can give you this? No, not really, right? So this appearance should make you think about lymphoma immediately. And probably the first 10 things in your differential diagnosis should be follicular lymphoma. After that, you should think about the exceptions we talked about, which is marginal zone lymphoma and mantle cell lymphoma and other lymphomas that can be partially nodular. But the CD20 here gives you so much information. And so without all of these other stains, already looking at the 20 should give you a pretty good idea that you are looking at a lymphoma, and chances are it's follicular lymphoma. All right, so I'm going to stop there and take any questions, because then we are going to move to the third case.
We don't have any questions, though the chat box is really active.
interfollicular area so much, but you can see a fair number of plasma cells even in the violent vascular type. Sometimes Castleman disease doesn't present as one thing. So I just want to, this is not to panic you, but this is actually the new WHO's I made this diagram taking all the chapters, and we are here with this case, but just suffice it to know, you can have the plasma cell variant, which will have follicular hyperplasia, and it has plasma cells in the type that's much more prominent. There are many other kinds of Castleman disease, and we will not be talking about this today, but just letting you know that this is the commonest type. 80% or so of Castleman disease is of this type, and so seeing this and the mixed type is not that uncommon, and it's defined by morphology and clinical features, and often the clinical is very important, especially in defining idiosyncratic multicentric Castleman disease and all of the other sequelae that come from here. And this will take a few hours. Okay, I want to show you some other follicular proliferations, HIV lymphadenopathy. These things are not biopsied very often, and they are recognized as they used to be, but you can actually see follicle lysis here, right? And what is follicle lysis?
The follicle structure is disrupted. Disruption of the follicular architecture.
And if you are not sure that you are seeing this, say, in a young patient, and you want to highlight it with immunohistochemistry, what marker would you get?
Dendritic cell markers, CD21.
Excellent. And what do you normally do? Is it CD21 or CD23? Which do you most often use?
21.
Okay, excellent. So great. This can actually be a very helpful marker in so many things. In the follicular lymphoma case that I showed you, the entire lymph node was clearly follicular architecture, but you can also have diffuse architecture or things that are partially follicular with progression. So CD21 can be very helpful to talk about, show you that there is a disrupted follicular architecture. In follicular lymphoma, is that go hand in hand with progression. In cases like this, HIV lymphadenopathy, this is early phases of it. There is no lymphoma here, but knowing that follicle lysis is, you can highlight it with CD21 is also helpful. CD21 is, I think, one of the most common markers that I use in my approach to diagnosis, primarily because it is very helpful to bring out architecture. It's true about the lymph node, also the GI tract and other common places that are biopsied where you may have small pieces of tissue. And even a follicular architecture is difficult to appreciate. So CD21 can be extremely helpful in these cases. Okay. I already have the label here of what I'm trying to show, but what is typical of PTGC? You don't have to read. You can simply tell me what you think.
Large follicles.
Large follicle shows 3 to 5 times size of a normal follicle, and Mandelson cells encroach into the germinal center.
Right, excellent.
The background of reactive hyperplasia.
Right, background of reactive follicular hyperplasia. All right, fantastic. And what do you need to look for? There is an association with progressive transformation of germinal centers and other lymphomas, right? So when you see this pattern, you have to pay some attention to rule out what. I mean, the answer is actually on the slide. Next time, I'm just going to put up a picture. But nodular lymphocyte predominant can also be associated with classic Hodgkin lymphoma, but much more commonly this. So when you see this pattern, you want to think about that. Okay, so before I move on to follicular proliferations, leave follicular proliferations and move on to diffuse proliferations, does anyone have questions? Okay, so are there any?
The chat box.
Okay, great. So diffuse proliferations, this can be anything, right? It can actually have, just wipes out the architecture. You don't have any particular information except that it's completely gone. It may not even be lymphoma, right? So let's just talk about something very typical. This is a 62-year-old man, 5 centimeter inguinal mass, had some B symptoms. Imaging revealed lymphadenopathy above and below the diaphragm, as well as splenomegaly. So this patient has a huge amount of burden of disease here. So lots of adenopathy and splenomegaly. And what do you see here?
Effacement of the architecture.
Complete effacement of architecture, lymph node architecture. The capsule is intact, but the rest of the architecture is completely effaced by the. And what I could appreciate was that if the tumor cells could have some amount of cytoplasm based on the pinkish, more pinkish eosinophilic hue, as we can see. If they were totally cells with scat cytoplasm, we would see a more small blue cell-like picture.
Right, excellent observation. So if you see something more pink, you are going to think about, what would you think about if this was a lot bluer than it is? I completely agree with you that when you see a lot more cytoplasm, it's more pink. And of course, you can only tell this when you have nicely fixed and sectioned, thinly sectioned, slides, right? So it is very subject to artifact. But when you have that, pink usually equates more cytoplasm or even a non-hematologic lymphoid malignancy. But when you have a sea of blue and it's completely effaced and you have no variation at low power and everything is just, more dark blue, we are not talking cell size, simply the pattern at low power. What are you thinking about? It's in a lymph node. And it could
Lymphoma.
This capsule.
So you're going to be thinking about small lymphocytic lymphoma,
Yes.
right?
Yes,
CLL, SLL.
Yes.
And what's the other thing you're going to think about?
DLBCL.
So DLBCL will, yes.
SLL.
How about mantle?
Mantle can have a diffuse pattern.
How about marginal zone lymphoma? I don't mean for this picture, right? I'm talking about a diffuse pattern. So you can have marginal zone mantle cell lymphoma. Mantle cell lymphoma would look a lot darker. If you are talking about a CLL, SLL, what should you see? It's usually not a complete sheet of the same cells. You see some variation at low power, right, for SLL, CLL. And what variation should you see? Proliferation centers, right? So it looks dark and light. So it's not a clean wipeout that you see here. Okay, and then can you see follicular lymphoma do this? That's right. Diffuse follicular lymphoma can do exactly that. So a pattern is not a diagnosis, and that's actually exactly what I'm trying to get at. And can you have a carcinoma or a sarcoma or any non-melanoma, any other non-hematologic thing do this? Yes, so this pattern is very broad, right? Okay. So this happened to be a diffuse large B-cell lymphoma. So now I'm showing you the pleomorphic large cells. It's positive for 20. The splenectomy actually shows these larger nodules, and then the cut surface really shows replacement, complete replacement, and a very fleshy looking appearance. And then in the spleen, one thing to know about when you are grossing in a spleen, when it has large nodules like this, it's actually really easy to see them, but there is something called a miliary pattern. So sometimes you do look at a cut surface of the spleen and you see just tiny little bumps and not these large nodules. And that can happen in diffuse large B-cell lymphoma, and it can happen in classic Hodgkin lymphoma. So a spleen should be completely sliced fully and multiple sections taken per centimeter of the spleen, and that's typically how you gross it in. But when you see nodules, of course, you can look at, nicely section them plus normal spleen for comparison. Okay, so as you all know, diffuse large B-cell lymphoma is the most common lymphoma sort of everywhere, different age groups, geographic groups. There are clinical prognostic indicators and different clinical settings. So I'm going to simply move on. And this is a picture that I created over time of DLBCLs that I have seen that have many faces. I like to think of this as the many faces of diffuse large B-cell lymphoma, and look how different and why you need to be thinking very broadly for this diagnosis. I mean, at first glance, almost nobody would call this a diffuse large B-cell lymphoma. It looks like something that's neural. Same thing here, right? Extreme pleomorphism. It can present within vessels, intravascular large B-cell lymphoma. It can look very ugly in an aspirate from the bone marrow, right? So all of these and very there's like almost signet ring cells, so can actually overlap with adenocarcinoma-like cytology. So lots of different faces. Okay, let's talk about starry sky. So I showed you this picture before. Very similar. So the stars in the sky are not the malignancies. The stars are really there to stop up high proliferating cells, right? And that's exactly what happens in the germinal center. In the body, it's the most proliferative normal thing that you have is the germinal center. And I heard the answer. So look at the similarity, right? And again, needle core biopsies, be very careful about needle core biopsies can be really treacherous, but the clinical here for Burkitt lymphoma can be very helpful, right? So everybody is familiar with these images. So these medium-sized starry sky, very high mitotic activity. The lymphoma is defined by a translocation, but it is aggressive and curable, and usually now in the new classification defined by having almost only MYC with a very small number of other mutations and not anything else, because lots of other things have a MYC rearrangement or MYC amplification, and that includes things that are diffuse large B-cell lymphoma and can be pleomorphic. All right, so I'm going to move on to the next case, unless people have questions. This is a 17-year-old boy with 3 weeks of difficulty to breathe, and he had a chest X-ray which was red as negative in a small outside hospital in California. He was treated for pneumonia because he was having, and this was in the wintertime. So the patient was treated for 3 weeks. They actually did a second X-ray, which was also not picked up and was read as negative. He then developed acute respiratory distress, and multiple attempts were made at this point to intubate the patient. The patient was actually emergently brought to the Stanford Hospital by Life Flight, which is a helicopter that is sent out to get patients when they are in an emergency situation. But he expired soon after arrival. And a massive mediastinal mass displacing the trachea was found at autopsy. So this is a very, very unfortunate case. I like to present this case very often about what should not be missed. This was missed clinically, so as pathologists, we really couldn't do much except kind of watch in horror as the story was told us, and the patient expired, before they could get a biopsy. So the initial read of this case was probably the most problematic. The treatment for pneumonia may have happened, but at least at the repeat X-ray, somebody should have picked it up before we got to this stage. And another important feature here is that when you have a patient who is so the emergency, the Life Flight, the helicopter are trained people, and one of the descriptions of a nurse who went along in the flight was that the patient was tripoding. So sitting down, the patient looks like a triangle when you approach them because they had so much difficulty breathing. They were bent over, trying to, gasping for breath when they actually experienced, because they couldn't intubate the patient. So that tripoding appearance. So if you ever have, clinical scenarios, these are things to watch out for. So this was autopsy material, so not the best preserved cells, but this is the panel that was done, and we actually have. So do you know the diagnosis for this case now?
ALL.
ALL. Yes, very good. This is not the TDT of this case, but I will say why. The TDT was a lot worse, but it was enough, but I will show you that. So it's a plastic-looking neoplasm. You know that it was growing very fast because between a perfectly healthy 17-year-old within a few weeks was dead. So it's certainly proliferating very fast. Sometimes we are required to make a rapid diagnosis. This can present in the CNS. It can present as an effusion. It can be in an FNA. It can be in the bone marrow. So in many different places that pathologists, AP or CP pathologists or laboratory people on a peripheral blood smear may be faced with blastic neoplasms. And so this can range everything from a lymphoblastic. It can be a myeloid sarcoma. So if it's in an extramedullary site, it can be AML. So certainly ALL, AML. You can also have blastic mantle, follicular. There are rarer things that you should be thinking about. And then a very difficult diagnosis when it's kind of a mix of lymphoid and myeloid markers. Now, it's very typical for us to do flow cytometry. I know not all centers in India do it, but many centers do. And so I've sort of given you what the typical marker profile can look like in these lymphomas. And this is also a picture of what a real TDT should look like. One of the pitfalls here is that the TDT stain is not always this clean and crisp, but it really should never be cytoplasmic staining alone. Sometimes you get a slide that looks very brown. Everything is positive, including your endothelial cells and histiocytes. Endothelial cells are a very good tip-off. If they are positive, be very cautious how you interpret the TDT. So DLBCLs can be misdiagnosed this way, especially in a BALL that presents in an extranodal site or the mediastinum. And so very important to pay attention to your TDT. Newer markers are coming out that actually we are testing as well. And so we may actually end up having a good TDT that doesn't have background staining, but it often does have background staining. Okay, so I'm just going to show you some slides from that autopsy. This is the trachea. And you can see that once it was fixed, it's basically like caking the trachea in. And so, this is just such an unfortunate case, but a good reminder for what not to miss. All right, any questions? I will move on to the next case.
There is one.
So Praveen asks, how do you approach a case of mediastinal mass true-kit biopsy where the differential is between thymoma type B1 and T lymphoblastic lymphoma?
Very good question. So lymphoblastic lymphomas overlap with thymoma, and when you have a mediastinal biopsy only, a true cut biopsy, it can be a very difficult task. For people who are familiar with and do flow, there are patterns of flow where you can look at maturation. So it's not a tight population that is expressing TDT, and a normal thymic pattern can be seen. So that can be very helpful if you have flow. If you don't have flow, morphologically, and if you're only looking at cells or a few cells on a slide, you cannot be sure what it is. And the same markers will be expressed. So in a normal thymus, you can have 4, 8 positive, 4, 8 negative, 4 or 8 cells, right? Like thymus is where T cells mature. They go through all of those stages of maturation that have dual expression or lack of expression of 4s and 8s or individual 4s and 8s. In addition, it's acquiring certain mature B cell markers, so they may not be on. So you can have a very atypical pattern in the normal, atypical pattern of T cell markers in a normal thymus. So it may be impossible to separate this. Couple of things that help you. One is clinical. If the patient has if an effusion, have them tap the effusion. If patient has a bone marrow that is involved, that can help you. So the one marker that I use in this situation is LMO2. That marker should never be expressed in a thymoma, and it should only be expressed in lymphoblastic lymphoma. So if you have LMO2, that is helpful. But sometimes, if you don't have that marker, there is a very nice paper from the Mayo Clinic group showing the thymoma versus lymphoma differential with that marker. So I would encourage people to look it up. But it's a very, very difficult diagnosis. And we are faced with this in the middle of the night on call because we take call for flow cytometry. And I could also call on Sumit if you have additional insights to say something, because the flow helps us a lot, looking for a normal maturing pattern of thymic development versus something that has an arrested pattern. That can be very helpful to pick out along with the morphology. Other tips is cytologic features. Sometimes the blastic lymphoid things are larger. It's a subtle finding. You may not always have it. Sumit, do you want to add anything about flow?
I couldn't agree with what you said. Reply to Praveen's question, a difficult, tricky situation in practice. A small thing I can add is many times CBC, the complete blood counts and the bone marrows of these patients look near normal. So if you have a high-end flow lab, it's a good idea to do an MRD evaluation. You could still pick up scanty T blast, abnormal T blast. So it can help. That's all.
Thank you, Sumit. That's very helpful. And the other thing I told you about tapping any effusions, that has helped me with multiple cases. If the patients have effusions, I usually tell them tap the effusion and send the slides. Even if I can just see the slide and confirm that there are blasts there or blastic-looking cells, it's extremely helpful because you will not have a thymoma giving you an effusion. So it's a very quick thing that clinically, if they're willing to do, you can confirm it right away.
There's another comment, ma'am, in the chat box. Dr. Soumya Ranjan Malik says that cytokeratin and P63 helps.
Sorry, I forgot that. Thank you so much. So if you have a true cut biopsy, that was the original question, the keratin mesh work in the background can be very helpful. So you shouldn't have, thymic hyperplasia versus thymoma has also differences in how the keratin pattern is in the background. So that mesh work can be very, very helpful to get it to thymoma. Yes, sorry for focusing so much on the lymphoma side of the question. You're absolutely right. Thank you.
Thank you.
Okay, shall I move on?
Yes.
Okay, all right. So is a 25-year-old college student who presented with shortness of breath, drenching night sweats, so has the whole, B symptoms, systemic symptoms, and a large mediastinal mass, which this came from. And so, we talked about the mediastinum just now. So this is the other side of the coin. Anyone want to describe it?
I mean, it shows a nodular growth pattern surrounded by the collagenous band, and in the nodule shows the lacunar cells and
Loss of polarity.
Yes, excellent. And still a nodular pattern, right? I went back to nodular pattern just to contrast. And I'm not going to talk much about it because I just heard from the announcement that Sumit is giving you a full lecture on this, so I'm going to move on.
nodular sclerosis, Hodgkin's lymphoma.
Excellent. Okay, I just want to take you through some nice pictures, but you will hear all about this, so I'm just going to skip it. Is that all right with everyone? Because you're going to have a full lecture on it, right, which will go over all this stuff. So I'm simply going to. And your diagnosis? Yeah.
Ma'am, what is there in the center of the nodule, that blue thing?
Apoptotic bodies, these are dense.
These.
These one, the lacunar cells are there, and in the center, the blue portion.
That is normal.
Yeah, it's okay. I think there are
Apoptotic bodies.
There could be apoptotic bodies, which is what I think this is, but also variation in how you cut and stain. There's a few here too, right? It's more intense. What's the other thing you can see in Hodgkin lymphoma? You can often, this particular case doesn't. This is just a very typical nodular sclerosing Hodgkin, but
You can see necrosis there.
yes, okay, that's actually what I was getting at. You can see granulomatous inflammation and necrosis. That's the answer I wanted to hear. So when you have a necrotizing lymphadenopathy, again, if you have a needle core biopsy, you should be thinking about Hodgkin as well, or lymphoma in general, but Hodgkin in particular. Especially head and neck lymph nodes, cervical lymphadenopathy, and you don't have an excisional biopsy if there is necrosis. Think about this. All right. Shall we move on to paracortical expansions?
Yes, ma'am.
Okay. All right. So this is a 19-year-old Filipino man, intermittent high fever, unilateral cervical adenopathy. Patient has no history of immunodeficiency. They did do a monospot test because the age was so appropriate for trying a monospot test. It happened to be negative in this patient. He was given antibiotics initially and was unresponsive. What do you see? I want pattern. I want whatever else you can tell me on the higher magnification images as well. Mostly this sort of. So what is this? We'll start with
There's a big nodular pattern.
vaguely nodular pattern, but what is the area? So you have these look like
Expanded. Paracortical.
yeah, exactly. So you see these expansions. when you
Paracortical
see-
areas.
Right, paracortical expansion.
Paracortical expansion is more.
And this is sort of a higher magnification of that expansion, say from somewhere here. I mean, could this be diffuse large B cell lymphoma? in pathology, if somebody says, could this be something, the answer is always yes, because it could be, right? You're always thinking of the exception. So that was a bad question. It could be, but it would be pretty rare. What I was trying to get at is what you're seeing here at high magnification is a mixture of cells.
Yes, ma'am.
You're seeing things that look like, what is this cell? What am I trying to show here?
Immunoblast.
Exactly. It looks like an immunoblast, large central nuclear light sort of looking back at you, right? So that is an immunoblast. Then you have other things. You have like little centrocytes.
Centroblast.
Centroblast.
This is centroblast, centrocytes, and lymphocytes.
Yes, and lymphocytes and histocytes.
Histocytes,
You
maybe
see
say.
exactly, mixture of cells.
Yes,
Over
ma'am.
here, right? Just mixture of cell types. I've given you a bunch of immunos. What do you think? You have CD20 positive cells, a range of them. You have CD30 positive, range of them. EBV. Now, kappa lambda is not often done, so I would just, if you just had these 4 immunos,
Towards because of EB, I would go towards immuno.
but can this be classic Hodgkin lymphoma? But you saw the last case where you had this beautiful morphology with very, very typical strap-like collagen bands and nodules. Very easy to make the diagnosis of classic Hodgkin lymphoma, right? Then you have this paracortical expansion, some immunoblasts, some mixtures of cells, and then you get this immunophenotype. Could this be Hodgkin lymphoma?
Yes.
And why or why not? What would make you rethink that? What else would you do? This is one trick if it works. Kappa lambda is not always successful, but if it works, it's nice, right? It really shows a mix of kappas and lambdas in the large cells. A little bit more kappa, but you can also see them. In classic Hodgkin lymphoma, if you do kappa lambda, sometimes the large cells are positive for both. That is a feature that Hodgkin lymphoma does have. It kind of absorbs, the Sternberg cells can absorb the markers in the cytoplasm. Okay, what do you think about the range of cell sizes? So can you be absolutely sure this is not classic Hodgkin? Would be a bad miss.
CD45.
Yeah, CD45 can be helpful. Yeah, yeah, CD45 can be helpful, but it's really extremely difficult to read it, right? Often because every cell is positive. So if you want to truly interpret, you need to go to cells that are back to back and make sure that the intermediate membrane is positive or not. So it can be helpful. There's another thing that we use very commonly in Hodgkin diagnosis. I think I had it a few slides ago. These, right? Transcription factors. So those can be helpful, but suffice it to say that immunoblastic proliferations can also have dim transcription factors. So that can actually be misleading. So your best bet is really to put all of these things together, the age, the clinical presentation. This patient happened to be negative for the monospot test. Usually they should be positive. So we looked at this patient a little more carefully. The fact that there is a mix of CD20, CD30, and EBER, usually these cells show a range of cells that are positive, and that should be reflected, whereas in classic Hodgkin lymphoma, you should have just the large cells. And if they are EBER positive, it should be just the large cells as well. Okay, this is another diagnosis that can involve the paracortical expansion. So basically the low power could be identical, right? Basically seeing nodules and then this expansion. And if you look at IgG and IgG4 stains, you can see that it certainly meets criteria. In fact, the IgG4 looks more than IgG, so it more than meets criteria. So this is when you have IgG4 involving the lymph node. And in the lymph node, it can have many appearances, anything from looking like Castleman disease to looking like lymphomas and a progressive transformation of germinal centers. So this is a very big mimic of a lot of other things. And it was relatively, it's only been kind of known about in the last 10, 15 years. We haven't always known about it. And this is very important not to mix up with a lymphoma. Interestingly, it can also occur alongside lymphomas. So it can occur in the background of T-cell lymphomas. It can occur with marginal zone lymphomas and many other types of lymphomas. So very important to pick this up. And when this is often mistaken for lymphomas or lymph node excisions happen. And the reason to also pick it up is because you can treat it with steroids and the patients get better. So very important to separate it from lymphomas. If there is a very prominent infiltrate of plasma cells, a kappa lambda should sort it out. IgG4 related disease, you should have polyclonal kappa lambda expression by flow or by tissue. So this should be relatively easy. And patients respond very well. Still not clear exactly whether this, this is defined as a disease now, but it is not exactly clear what triggers it. And this particular patient also had pancreatic biopsy and a very extensive disease. This image can be very easily a patient who has bulky disease from a lymphoma, particularly, head, neck, and thorax. So you can see that. So it can be extensive. It can occur in any age group. So a big differential diagnostic consideration. So you need to think about this. So sclerosis and having increased plasma cells are very important. If you see thrombophlebitis, that is good, obliterative thrombophlebitis, but you often don't have that feature. That's the kind of third feature that you see for IgG4 related disease. You can more often see that in the pancreas. Very rare to see that in the lymph node.
And I have one doubt regarding that. In such a case, if we don't see any systemic IgG4 related involvement, then we should keep this differential in the last criteria. If in the patient we don't see any other.
Completely agree. Completely agree. I didn't put up I do have a full presentation on this as well and the overlap, but basically there are very well-defined criteria. John Chan, the Chuk and Chan criteria paper is wonderful, and there are many other papers that have come. So one that describes the histologic patterns, which are several, then the histologic mimics that go with other diseases. There's a lot of very carefully done measurements. And then apart from all of the histology and the IgG4 increase, you also have to have serologic confirmation and clinical confirmation. So yes, it's a multi-part diagnosis. Very often, like the way you make a diagnosis of Castleman disease, the clinical criteria need to fit, or myeloma for that matter. There are several criteria that need to be met. So just seeing IgG4 cells, increased IgG4 cells, is not IgG4 related disease. So absolutely right.
Okay.
There's a question in the chat box. Dr. Soumyaranjan asks, what is the ratio of IgG and IgG4 in the lymph node?
So you follow the same criteria as defined in the pancreas and other places. It can be focal. Usually high power field, it's defined by high power field having more than 100 or more than 40 40% if you're looking as a ratio of IgG4. This case is pretty clear because as a ratio, where is it? Oh, sorry. As a ratio, where did it go? I'm sorry. Yeah, as a ratio, it looks more than 40, 100%, because the IgG isn't actually picking up that much. So the denominator here is a little off. It should have at least as many cells. But if you are close to 40% or way less than 40%, you should look at different areas, because sometimes you see that accentuation only in a couple of follicles or focal areas, and you don't see it everywhere. So you can't use cutoffs that are, and of course, when you narrow the area that you're examining something, you can get to 40% more easily. So need to be careful how you evaluate that. The standard criteria are 40 and then 100 as a high power count, but be careful how you apply them. And also always good to have the serology confirmation. So, communicating with your clinician. The criteria or the international guidelines for this also call for a 3-part diagnostic line when pathologists do a diagnosis. So if you have all of the criteria met, very easy to call it IgG4 related disease in your top line. If not, you can say this has IgG4 related disease like features or increased IgG4 confirmed with clinical. So there's these tiers that you can use so that the clinical will fill in the rest of the gap before you make that final diagnosis. I mean, steroids are an easy way to treat, but it also has its downsides. And if you don't need to give anybody anything, that's a better day. Okay.
There is
I also,
question.
yes.
If I may. Yeah. So Vanessa asked how to differentiate inflammatory myofibroblastic tumor from IgG4 disease in the lung tumor.
Excellent question. I'm not going to answer that today, if that is okay with you. Okay, it takes me way away, and I'm going to need to put up criteria side by side to do that. I want to present one other point about this particular patient, because that brings up a different differential diagnosis. Prior to initiating treatment, the clinician was worried in this case that not everything seemed okay, and they decided to take another lymph node out. And that lymph node, because it was done at Stanford, where we typically run the flow at the same time rather than coming to us from the outside, like the rest of the biopsy, the patient in the meantime was transferred to us. Luckily, that lymph node got flow cytometry. Somebody want to tell me what you're seeing here?
G4 double negative.
Yeah, you're seeing a C4 and 8 double negative population. It's also very skewed T cell receptor alpha beta, hardly anything here. What does that tell you?
That
Does IgG4 related disease have this?
no.
No, right. Okay. So something else is going on, and the clinician's suspicion was correct. Something else was going on.
Some lymphoproliferative towards lymphoproliferative.
Yeah, do you think there could have been a T cell lymphoma in the background that we missed? It does have a paracortical expansion. It does have, possibly. What else should you be thinking about? So patient still has something. Right, this. People heard of this autoimmune lymphoproliferative disorder?
Yes.
Okay, so you may not always be able to pick up a 4-8 double negative population in a lymph node by immunohistochemistry flow. It's so much better to pick this up because you can really define the population. In this particular case, you actually can see that 4 and 8 doesn't equal all of the 3, right? You can't always tell this in most lymph nodes, but in this case, it was sort of beautifully obvious that you do have a double negative population that is expanding the paracortex. So usually, autoimmune lymphoproliferative disorder is there are mutations in the FAS apoptotic pathway plus some other genes in that pathway. So germline genetic mutation testing needs to be done in these patients to establish it. This is a big mimic of T cell lymphomas. So, and ALPS, in the background of ALPS, you can have the patients with ALPS and those genetic mutations have a preponderance also to develop lymphomas, including T and B cell lymphomas. So there's multiple complications with these patients, but this is an inborn or acquired mutation in patients, and it can give you these findings. So this patient actually had IgG4 related disease and autoimmune lymphoproliferative syndrome, and that explained the adenopathy everywhere. So patient and the pancreatic mass. So the patient actually had both in the same lymph nodes. We not in the pancreas, but certainly in the lymph nodes, and we went back to the prior lymph node and it had the same findings. And then last but not least for this differential is a peripheral T cell lymphoma. So not to miss, here you see the normal follicles and then expanded paracortex. And here you can really see that these cells have cleared cytoplasm, more atypia. I told you before, marginal zone lymphomas can have this cleared cytoplasm appearance, this monocytoid appearance. But in the T cell lymphoma, you can see much more atypia. You also often see eosinophilia, right? So this is actually the malignant counterpart of what you shouldn't miss in a paracortical infiltrate. So here's your CD20 and your 3. Very clearly shows that this paracortical expansion is all CD3 positive cells. And then the first example I showed you is really a peripheral T cell lymphoma NOS, but as you know, follicular helper T cell lymphomas can also have that pattern. These are much more effacing, so typically they have a diffuse pattern, but it can have very, very prominent vasculature in very, very prominent dendritic cell expansions. And then TFH markers such as PD1 and CD10, and there are several others like ICOS and CXCL13 that can also help you with this diagnosis. And by the way, the double negative T cell population I showed for the ALPS case can also be seen in T cell lymphomas. Usually by flow cytometry, you can also pick up other abnormalities like 3 loss or 2 loss. This case had beautiful 3, but you can also see flow immunophenotypic abnormalities that can be very helpful in going after this. And then now we know that you can also, T cell gene rearrangement can be done, and mutational profiling. So there's many nice mutations described like ROA and IDH2, DNMT3. So if you do molecular profiling, those can also be picked up and confirm the diagnosis. Okay, so I don't know when I should stop, but I will try to continue sort of the sinusoidal patterns. Sumit, if I need to stop, please let me know.
Pretty fine. I think Yashua is doing great. There are still approximately 170 students attending, apart from the 5-6 serious students with you. The crowd is here, so
Okay,
go ahead.
so I will keep going and you can just stop me when I should stop. Okay,
Sure, thanks.
let's go to the sinusoidal pattern. This is a difficult pattern. You have to be cognizant of where the sinuses are. So there are subcapsular sinuses, there are sinuses in the middle of lymph nodes, and so looking at sinusoidal patterns, and they can be partial. And I think we had a question when we were looking at follicular patterns about dermatopathic lymphadenopathy. So that is definitely something to think about. And then I've given you some differential diagnostic considerations. And just like the diffuse pattern, this is something that brings up a lot of non-hematopoietic diagnoses. So, thinking about getting a keratin and thinking about getting S100 or, SOX10 or whatever marker that you get for melanoma, those are very important with sinus proliferations. And sinus proliferations and paracortical expansions, if they are very in later stages, you may not be able to tell that they're paracortical versus sinus if those landmarks are obliterated. So that is also, this overlap can also blur your diagnostic approach very often. All right, so this is a 15-year-old with a right cervical and retroperitoneal lymphadenopathy. And then they took out a cervical lymph node, and it came in with an outside diagnosis of reactive hyperplasia with immunoblastic proliferation. So you can see that there is a proliferation or population of things. It looks very pink, and it is obliterating maybe the sinuses or the paracortex. It's hard to tell, all these in-between areas. The hilum is here, and typically you see this normally in an inguinal lymph node, but this particular lymph node had it. And this is what the a higher magnification of the nodular part. So this basically, I have expanded this part here. So does somebody want to tell me what you think?
It seems to me to be have a mixed architecture, with one part of the lymph node showing complete effacement of the architecture on the left half, and the other half showing a follicular nodular pattern in which the two nodules, follicles, you have focused on the higher power. And the nodules per se, there are some areas, darker stained areas, that seem to be of a part of a remnant follicle left behind that you pointed on the laser, and some other areas which is totally been replaced. And again, I feel that because of the more pinkish staining in the tumor mass, there's probably they have some cytoplasm. So I'm tilting towards a large cell type malignancy.
So the next pictures are taken from the edge of one of these, like here. I'm actually focusing on one of the sinuses here, so giving you a little bit more information, especially here. So you are seeing parts of a remnant germinal center here. So I completely agree with your answer, brilliant answer. But then this was a very difficult node to look at because it had parts that looked perfectly fine. Maybe this is part of a mantle, we don't know, small compact cells, but very disrupted. And this looks nothing like a normal node, right? It's clearly very disrupted. But these sinusoidal areas, had things going on. More, even higher.
Is it have the histiocytes internalize some cells?
I don't think so. I don't think there's emperipolysis or hemophagocytosis here, if that's what you're getting at. I have another example I can show you, but yeah, so lots of cytoplasm. Nuclear outlines bother you? This is a tough case. And outside I already told you it had been diagnosed as a reactive hyperplasia with an immunoblastic proliferation. So it's an excellent idea. But there's also sort of,
Mike, can you see some horseshoe shaped cells there?
Yes.
aha,
In
very
center.
good idea. Very good idea. Horseshoe type cells. But then it has, some plasmacytoid cells, normal lymphocytes, and then again, kind of not great, right? So what is crawling through the sinus is the question. All right, let's keep going. We did some immunos. So CD20 just sort of pushed aside. We are seeing CD3 and CD5, but look at the 30. Right, I have more pictures. Starts to get scary. Granzyme stuffing the sinuses, these cells, and then they're also kind of going into those nodules. Right, so we did an ALK. So this is actually an ALK-positive anaplastic large cell lymphoma. It's a tough case, and we also, as you already know, small cell variants are even worse. I don't know that this was entirely a small cell variant, but it certainly didn't have the very pleomorphic cells. But I think somebody answered saying that could be a hallmark cell, and that's exactly right. And then the sinusoidal growth pattern can really overlap with a distribution of histiocytes, so there could be normal histiocytes there that can also mask, and then other non-hematopoietic tumors. So I'm just going to show you some pictures. This is much more typical when you have a pleomorphic set of cells. It's much easier to see. This is also stuffing up, just lots and lots of atypical cells in the subcapsular sinus here in this case. The lymph node at low power tends to look pink. So you can see that too. We saw it in the first case I showed you. It looks very, very pink. And then this pleomorphism, which the case I presented does not have. So again, large atypical cells. And you can have, so I'm showing you both versions of ALK. The case I presented had the NPM ALK translocation, which is the only one that has a nuclear and cytoplasmic stain. And then all of the other, and that's the majority of ALK-positive anaplastic large cell lymphomas have that translocation. And then you can see the cytoplasmic ALK, which there are many partners to ALK in this cytoplasmic one, including duplication. And you can see this sort of pattern. And then, you confirm by FISH if you need to. And then if it is negative for ALK and it still has prominent CD30, like the case I showed you, then ALK negative anaplastic large cell lymphoma would be the answer. Okay, so other things in the differential diagnostic considerations for a sinusoidal proliferation, you can see this beautiful sinusoidal proliferation, right? LCH, and you have eosinophilia here, very clefted, large atypical cells. And I've given you some information. The imaging studies for LCH is very classic. Usually even in an X-ray film, a good radiologist can just tell you that the first 10 things in their differential diagnosis is Langerhans cell histiocytosis, because the imaging findings are very typical. And then now we have a lot of markers, including BRAF, that we can do, and BRAF has an immunohistochemistry, so you can do this by IHC. Here's more pictures of it. So the eosinophilia should make you think about it. But remember the paracortical expansion, which if if it obliterated the sinus and it is a peripheral T cell lymphoma, can look exactly like this too, and you could miss these cells. And then the Burbeck granules, which EM, if anybody does that, can also show you these racket-shaped ones. This, for whatever reason, in the US, this is a favorite. The picture I put here is simply to show you that because it's a favorite board question. Comes up all the time, USMLE and pathology boards. All right. This is somebody already raised this differential. This is a 4-year-old boy with a massively enlarged bilateral cervical lymphadenopathy, no pain or tenderness, and no other sites of disease. So just massive cervical lymphadenopathy, very classic presentation. And pattern, anyone?
Marked sinusoidal dilatation. There is sinusoidal dilatation with some follicles.
The small follicles.
And
cortex and medulla cannot be differentiated.
Here the sinus are expanded by the histiocytes, and the histiocytes have in the inset, which is the high magnification image, we can see that the histiocytes have abundant eosinophilic cytoplasm with some vacuolation also being appreciated in some histiocytes, and we can see empiripolysis, and not empiripolysis, we can see that what we can say in morphology is that various types of cells, most predominantly small lymphocytes, have been internalized by the histiocytes, and some histiocytes show some cell debris, some show cells with intact cellular architecture, most show cells with intact architecture, but some few show cell debris. And
Excellent, thank you both. So here are more pictures. And emperipolysis is what you were describing so well. And S100 is the traditional marker. Now we have many others that can also do a good job. So here is a question for you. This appearance, is it pathognomonic for this disease? If you see this cell or cells, is it Rosai-Hoffman disease?
Not pathognomonic.
Right.
There can be other conditions also.
Right, so it can be non-specific, right? It can be a non-specific finding in lymph nodes, just like hemophagocytosis can be. And in hemophagocytosis, the difference is that they engulfed
lymphocytes.
Yeah, no, actually the type of cells can be the same, but they are usually more destroyed, right? Because in hemophagocytosis, it's really a phagocytic function, and you see remnants of cells much more commonly. In here, the intactness is more common. You can sometimes see remnants, but usually you see intact. And both of them, you see nucleated cells, and that's really the definition. Seeing any remnant, because histiocytes function is phagocytosis, so it's going to be eating up a lot of debris. So the debris doesn't count. You really need to see nucleated cells within the cytoplasm. And then, okay, so I told you about the marker. We now know that, so Rosai-Hoffman disease, or the original name, which is sinus histiocytosis. Yeah, so this patient is a perfect, no, there's sinus histiocytosis
with massive.
And this case actually is from Dr. Dorfman's files. He worked at Stanford. He actually founded our department. So this is one of his classic teaching cases, which I have now the privilege of using. And the mutations, up to 50% of these cases now have mutations. So it is actually classified as a neoplasm. So for a long time, we thought that this was a reactive condition. It's still clinically a very indolent disease unless it's in the wrong place, when it can cause some problems. But other than that, it is really something that resolves itself. Okay, so here is something where I tried to manage a sinus pattern that has very large atypical cells. You can even see pigment in some of them. So don't forget to think about getting keratins. It's S100 positive, of course, because it's a melanoma. So things that can mimic that. All right, so if you have any questions, then we go to the last case.
Yes, ma'am, there's one.
Okay.
Can you diagnose LCH in a case of sole lymphoid lesion without any bony lesions and skin lesions in an adult female?
You can. You just have to make sure that, yes. So I did take out some slides. I actually have a picture of LCH in a lymph node next to RDD. The two of them, Rosai-Hoffman, they can occur together, but that's not the question. The question is, can you make that if you only see no lytic lesions and only in one place? And the answer is yes, you can. It is probably less common. And if you do see a typical LCH lesion, just make sure that it doesn't, you either have the BRAF stain or the mutational analysis, which we tend to do now that it is known for confirmation. You don't need those to make a diagnosis. So if you are making a diagnosis, it is a very limited biopsy or a localized site, just make sure to get a radiologic correlation. In this diagnosis, the radiology is fantastic and the correlation almost confirms it for you. In the lymph node, so bone radiology is much better, of course, when you have bony lesions, but you can get the imaging and staging information to make that diagnosis.
Yeah, so just one question. Would you comment on CD1A positivity in dendritic cells in dermatopathic nodes? Does it mimic? Because that may be the question from your audience.
Got it. Okay, yes. So when you have CD1A, you have an overlap, right? So in histiocytoses, so you have basically what do you need to think about in histio? You need to think about dermatopathic lymphadenopathy. You need to think about Langerhans cell histiocytosis. You need to think about Rosai-Hoffman disease. You need to think about Erdheim-Chester disease. And then in a more pediatric case like JXG, juvenile xanthogranuloma. And so that's sort of your spectrum that you're thinking about. Many of the markers overlap. S100 can be positive in many of them. CD1A can be positive in many of them. So that alone doesn't. So this phenotype is not unique. This is actually helpful, but you can have this exact phenotype with dermatopathic lymphadenopathy. This is where confirming with your BRAF mutation-specific antibody. Is that available, Sumit?
Yeah, BRAF is available in few centers. Yes.
So confirming if you're not sure is important. If the patient has a history of skin rash, etc., that could be very helpful. Finding melanin pigment can be very helpful, right, in dermatopathic lymphadenopathy. So sometimes it's not the majority of the cases you can differentiate them more easily. But 1A, Langren, S100 can all overlap. So the newer markers are very helpful. Similarly, where's my Rosai-Hoffman case? Several of these markers can overlap. Cyclin D1 can be also seen in reactive histiocytosis, so it doesn't differentiate it. But OCT2, PU1, these transcription factors are actually very good at highlighting these cells, and that is more unique to Rosai-Hoffman disease. So some of these newer markers have given us, and we don't typically do molecular for this. It's distinctive enough that you can do without. And then, so definitely the answer is dermatopathic lymphadenopathy. And sometimes dermatopathic lymphadenopathy can be pretty overwhelming, and it can efface the node. It starts as a sinus, but it can be very, very extensive and definitely can overlap. Okay, anything else, or we just move to the last case?
That's it now. Yeah.
Okay. All right. Again, I gave you my case examples are very typical because I'm trying to make a pattern point and not diagnostic point, although it's related, of course. Anybody want to tell me what you're seeing?
The lymph node, the HNA shows two areas. One area on the right side shows a lymphocytic, predominantly lymphocytic infiltrate, and above that you have a lymphohistiocytic infiltrate, where there is adjacent to area of increased histiocyte proliferation and admits with some lymphocytes. And the histiocytes, some histiocytes in the image on the left show apophagocytosed cell debris, as well as some apoptotic cells are seen. Apoptotic cells are seen, and then there are some histiocytes with signet-ring-like appearance with peripheral nuclei, because these have phagocytosed cell debris. So based on that, it can be one of the patterns seen in based on that and based on the ethnicity of the patient, it can be Kikuchi-Moto disease.
And I included that only to tip you off, and so that's great. You picked up on that. And I want to hear from, I think two people have spoken quite a lot and given me wonderful answers. Somebody who has not spoken up yet, please tell me what other things are in your differential diagnosis.
Sabah, Dilsha, Santa, and Kavita. Any one of you, please try.
I want one each from you. Differential diagnosis for, so this basically is a necrotizing picture, right? It's sort of mixed up. It spans, doesn't really fit into any of the other sort of 4 big compartments we talked about. So the differential diagnosis is broad. The first diagnosis is a good one that was suggested, but I want each of you to come up with one more.
Kavita, you're not spoken. Why don't you say something? Kavita?
Necrotizing granulomatous.
Yeah, it could be a necrotizing granulomatous lymphadenopathy. And the etiologic agents, are you thinking something infectious? Yeah, give me one infection that can do it. Look exactly like this.
EBV, leprosy, histoplasma.
Excellent. Okay, excellent. EBV as well, right? It can actually have this. Generally, when you have an infectious organism, we don't really know the etiology of Kikuchi, and many people have gone after infectious causes. But other infectious organisms that you have just mentioned, you can detect them, right? Either by staining, serology, or culture. So any of those things are available for correlation. Outside of the infectious world, what else can cause this?
Yes, lymph node infarction can cause another picture.
Excellent. Lymph node infarction.
NHL.
Non-Hodgkin's lymphoma.
Lupus.
So non-Hodgkin and Hodgkin lymphomas can cause it. Generally, when you see necrotizing,
Lupus nephritis.
that is correct. Lupus can cause it. So autoimmune diseases.
And
In infectious and neoplastic situations, you can also, when you see this, you don't necessarily see that the necrotizing areas lack neutrophils, right? Infectious, you often have acute inflammatory, so it's an ulceration or acute inflammatory. See the same thing in EBV, but you may see this picture. So thank you everybody for participating in the differential diagnostic consideration. I want to keep the differential diagnosis as broad as possible. So that was what this exercise is about. So I think I've given you a lot of things, but you have already answered it. What is, am I trying to point out here?
Necrosis.
It is necrotic. And
Without
necrosis. Yeah, exactly right. Crescentic histiocytes. Is there something you can do to bring out those crescentic histiocytes? Some marker. You don't have to do it for this diagnosis, but if you want to.
CD68 myeloperoxidase.
So you can do any of these markers. That's correct. This can also have phases, and sometimes the late phases can be very effacing. So somebody mentioned systemic lupus erythematosus. There are 2 different particular findings which you don't often see, but I'll show you pictures of it. So you can, so this is what, if you were to stain up a Kikuchi lymphadenitis like in the patient I presented, this is what you would see. What gets people is that it can often have a very prominent CD8 infiltrate and a high proliferation rate. So typically can be mistaken for a lymphoma. And especially when younger people have a diagnosis of T-cell lymphoma based on this, you should be very wary. So do your MPOs, and these are not specific. MPOs are not seen in all necrotizing lesions, but Kikuchi is not the thing. Kikuchi or lupus are not the only ones that show you MPO positive crescentic histiocytes, so that is non-specific. You can also see follicular dendritic cell expansion. Sometimes they can form, clusters like this. And these stains, again, are not all necessary, but when you see them, they can be scary. Very commonly mistaken for a T-cell lymphoma. These are the 2 findings, and I'm showing you pictures because these are really hard to see in normal lymph. So you have see these sort of smeared out DNA bits, and then you can also see fibrinoid necrosis around vessels. And so these have particular names that are named after, like this one, a pathologist who described it. So this is another infectious disease, again from a cat, can have microabscesses. This tends to have neutrophils, so it can be separated, and there's also organisms that you can bring out using special stains. And we don't see leprosy very often, you do. So that is something that if we see it, then it gets shown around to everybody. So that's a very good answer as well. Okay, so I will wrap up with some take-home points. I like to use a very methodological approach when I examine a lymph node, because I think it improves your differential diagnosis and avoids any common pitfalls, or many, not all, but you can avoid a lot of things if you methodologically look at each and come up with what this can be before you embark on doing immunohistochemistry and molecular and other studies. So the architecture offers a lot of important clues, and some of this becomes truncated when we have needle core biopsies or true cut biopsies or smaller biopsies. So that's very important also to remember. Fibrosis, inflammation, necrosis can mask tumor cells, particularly in places like the mediastinum or even more difficult retroperitoneum. So these are things to remember. And also always connect it up with your clinical context and reach out to your clinician if there is not enough diagnosis. There's also multidisciplinary conferences. So if something doesn't fit, doing all of that ensures that you make an accurate diagnosis. So I will stop there and take any overall questions. And sorry for such a long session.
Lovely picture.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
for a nice potpourri of cases with such diverse cases covering all patterns. And I can tell you, and I think I speak for many of the people when I say that I didn't know how the time went by. 2 hours, easiest 2 hours I've ever passed. So it was very interesting, not a dull moment. Thank you so much. I have one question from my side that being a hematopathologist, we usually get a lot of biopsies in which many times we get incidental lymphoid follicles where there is no primary diagnosis at that time. And we tend to do 3 and 20 as upfront if for initial typing. And many a times we face challenging situations in which we get a mixture of both the antibodies, some T and B in a lymphoid follicle. So how do you approach such cases?
Excellent question, and I do exactly the same. I would start with a CD20 and a 3. If the follicles morphologically don't look like they have tingible body macrophages or polarization, I would maybe add a BCL2 to that. I usually do iterative immunohistochemistry, then do a large panel. I know that that is a luxury of being in an academic center. I think sometimes we have large panels you can put on a large panel upfront. Some people prefer that approach, but I think my preference is really to use the pattern approach and to choose and then do another round based on what the initial patterns give me. So your approach is a really good one. That is the one I follow. I start with a 20 and a 3. Sometimes based on the initial morphology, I may add a BCL2 or I may add a CD21, 1 or 2 other markers to bring out something that I get tipped off by looking at the histologic picture.
Right, ma'am. Ma'am, in cases where you get where you do not get a clear-cut answer, right? Like if you're in a getting a bone marrow biopsy with a diffuse CD20 positivity in a follicle, then it is quite easy to decide on the markers ahead. But when you're seeing a mixture of 3 and 20, so do you outright label it as reactive if the clinical picture is not matching, or do you do some additional immunostains?
Very good scenario. We face it every week, multiple times on our bone marrow service. So if you have a patient who has nothing else and you're looking at a bone marrow, first I would focus on where is the aggregate. Is it an aggregate? Is it an infiltrate? So is it a paratrabecular lymphoid aggregate? Is it non-paratrabecular? Is it diffusing? If you look at the aggregate, you can see that the cells are trickling into the surrounding area, or is it very well circumscribed? So these are things that give you. And if it's slapped up against the paratrabecular, against the bone, you're pretty sure that you better go look for that follicular lymphoma or some other lymphoma, right? Sometimes. So before you do any markers, if it is expanding interfollicular areas or an infiltrate, try to see whether there's any particular pattern that you pick up. There are lots of things, or is it just lymphoid, or is it lymphoplasmacytic? So these are things that can give you some information. Now, it is typical for us to have a peripheral blood and an aspirate, bone marrow aspirate at the same time as a core biopsy. So when we look at it, we actually, do the whole thing. So we can also go and see whether there are, cells that look like marginal zone cells, or, is this something else? So that's helpful, aspirate as well. But I know that some people only look at cores, so where the aggregators can be helpful. Now, going to markers, many of the follicular lymphoma markers like CD10, almost all of them, are downregulated in the bone marrow microenvironment, and this is a true physiologic state. So if you have something where there is a mix of CD20 and CD3, the aggregate is sitting in the interfollicular area and not against the trabeculars, and if it is well circumscribed, you are pretty sure that it's probably reactive, especially in an older patient and there's nothing else going on. Then but that's not what you're asking. You're asking what if it is in a paratrabecular or non-paratrabecular location, and if you have balance of 20 and 3 and it's 10 negative, BCL2 negative. I mean, if any of them are positive, that's fine. Typically, I don't actually do it. I do 20 and a 3, and if it is a majority 20 or based on the location, I would come up with something, or sometimes call it atypical lymphoid aggregate and then give them a differential diagnosis, particularly staging to see whether the patient has lymphadenopathy or any other diagnosis. So it is not, and the physiologic downregulation of these markers is real. It's not that your stain isn't working. That is at the majority of them. Every so often, you also get T-cell lymphomas. They can efface the marrow, if or Hodgkin lymphoma. You can have segmental areas where that's fibrosis. But some of these lymphomas can bring their microenvironment with them in the bone marrow. So you can see an angioimmunoblastic T-cell lymphoma, for example. It will have that meshwork of histiocytic and dendritic CD21 positive meshworks along with it. So you can certainly see that, and that can be helpful as well.
Thank you so much, ma'am. Now I would like Dr. Sumit to say the final comments.
Thank you very much. Yeah, so we thoroughly enjoyed listening to you and learning with you. Thanks so much. And everybody, still there are 100 people, they don't want to leave you, but I'm sure you have to go for work.